Hello, my name is Dr. Kelly Roof, and thank you so much for joining us for another installment of the Dutch webinar series. Today, we're excited to welcome Dr. Carrie Jones, who will explore the gut microbiome's role in hormonal and neurotransmitter shifts during menopause. So, if you don't know Dr. Jones already, she's an internationally recognized speaker, consultant, author, and educator in women's health and hormones, bringing over 20 years of experience to our discussion. Known as the Queen of Hormones, Dr. Jones is a naturopathic physician who completed a 2-year residency focused on women's health and endocrinology. She earned her Master of Public Health and became one of the first to achieve board certification through the American Board of Naturopathic Endocrinology. As a Menopause Society certified practitioner, she has served as the first medical director for us for Precision Analytical and the first head of medical education at Rupa Health. Currently, she's the chief medical officer at New Ethics Formulations. In today's webinar, Dr. Jones is going to dive into the intricate relationship between menopause, the microbiome, and hormonal changes. She'll highlight how the gut microbiome often gets overlooked during menopause, despite its critical role in hormonal and neurotransmitter shifts. The discussion will cover the perimenopausal transition, the inflammatory state linked to hormonal changes, the effects of hormones on gut health, and the connection between gut health and mental well being. Additionally, she'll emphasize the importance of addressing blood sugar and insulin resistance during this transition, along with the risk factors for depression and anxiety in menopausal women, among many other topics. If you're ready to start using Dutch testing in your practice, sign up as a registered provider today. Click the link in the chat and complete our provider application form. It's really easy, and a member of our onboarding team will walk you through the steps to set up an account so you can begin taking advantage of all the education and resources that Dutch has to offer. Plus, registered providers gain access to the Mastering Functional Hormone Testing course, the Dutch Interpretive Guide, and one-on-one consultations with Dutch clinical educators. This dedicated support and education is designed, of course, to help you become the hormone expert. If you have any questions as we go, please submit them and we'll do our best to address them in a follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. It's such a pleasure to have you with us today, Dr. Jones. We always love your webinars. I just hear that over and over and over from people. Love your webinars. Excited to hear what you have to say today. So take it away.
Hello and welcome to the Dutch webinar, Menopause and the Microbiome, Unraveling the Gut's Role in Hormonal and Neurotransmitter Shifts. And honestly, I think this is going to be where a lot of research is headed. I'm starting to see it already as women are entering through that menopausal transition. Obviously, a lot of press goes around hot flushes or night sweats or bone loss, and with good cause. But what nobody's really looking at is the microbiome and menopause. It gets forgotten because gas and bloating isn't really a common symptom, or it's not thought to be a symptom of menopause, unlike some of the other popular symptoms. So we're going to go through this because I really want you to understand the gut microbiome changes in menopause, like what's actually happening as she's making the transition to having a lot of hormone to having not very much hormone. Then we're going to talk, of course, about the gut-brain connection and how that's playing a role in her mood, in her brain fog, in how she's thinking as she's moving through this transition. And lastly, what do we do? Based on the literature now, how do we support the microbiome for the woman making this transition? If you are newer to the perimenopause-menopause transition, I just want to give you some background so we're all on the same page. A premenopausal or cycling woman makes sense. These are the years between puberty and perimenopause. This is when you expect her to be cycling. She may not be for various reasons, but this is the age. These are like after puberty to late teens, 20s, 30s, maybe even into her 40s, of course, where she's cycling. Then we get into the perimenopausal transition. This is the 6 to 10 year period where things start to go awry. This is when some chaos happens. So she may start out having regular cycles, but then in stage 1 perimenopause, that's when her cycles start to change by about 7 days, according to the definition. And as she moves through in stage 2 perimenopause, her cycles are now changing by about 60 days. This is when she's starting to skip cycles. Hormones are really starting to shift. Lastly, we get into the fully postmenopausal transition, which honestly, when she goes the 13th month, I should say, of no cycle, she's considered postmenopause. So 12 months no cycle, the next day she's postmenopausal, like just like that. So we consider this whole section of time a transition because of how long it is. Now, again, if you are not really understanding or maybe newer, maybe you're in a different area of expertise and hormones are newer to you, what the first hormone to drop is typically progesterone. So as she moves into perimenopause, she may ovulate, but the surge of LH isn't as strong as it used to be, or corpus luteum that produces progesterone isn't as great. And then with time, estrogen bounces around because the other hormone, FSH, is kind of yelling at the follicles, do something, make a hormone. So estrogen goes up, estrogen goes down, estrogen goes up, estrogen goes down, and eventually it too will drop down nice and low in the postmenopausal range. Now, she can have these hormones drop in her 40s. She can really feel them early 40s, mid 40s, late 40s. I actually have friends and colleagues that are still experiencing perimenopause in their 50s. But please remember, this is all around her cycle. If you have a patient or client who has had surgical menopause, they've had a full hysterectomy or at least no ovaries, then they are immediately considered surgical menopause. So they go from having hormone to no hormone basically the day of surgery once the ovaries are removed. So she skips the entire perimenopausal transition for the most part, unless she's having surgery while she's in the perimenopausal transition. So I do want to acknowledge a lot of these definitions around the menstrual cycle, and that needs to be updated, but we're not there yet. We still consider everything with these definitions around the cycle. Now, as she's making this transition, this entire change in the body is an inflammatory state. It's largely because of the decline in estrogen levels. And when estradiol declines and shifts, it's going to shift the balance in the immune system. So we get a shift between the pro-inflammatory cytokines and the anti-inflammatory cytokines. And in some research articles and books, you will see it called inflammopause. So again, we're thinking maybe hot flashes or night sweats or brain fog or bone issues, and all of that can really center around inflammation. So inflammation, when you're working with somebody with going through this transition, through the menopausal transition, you want to make sure that you have a really tight eye on her inflammatory cytokines. Where is this inflammation coming from? And like I said in the very beginning, this can manifest greatly in the GI tract. Now, in her cycling years, you've probably spent a lot of time working on her GI tract, and you're going to have to do it again as she goes through this transition. Now, here's why. When she is cycling, when she's in her younger years, she has this great bidirectional relationship between estradiol and progesterone and the microbiome. And it causes a lot of diversity. Those two hormones, along with everything else, diet and lifestyle and genetics, etc., increase microbial diversity. And that's what we want. We want the microbiome to have a lot of diversity. We don't want either the bad bacteria or parasites or worms or whatever to inhabit it, but we also don't want to skew one way or the other in terms of like Bacteroides or Firmicutes. Like, we want to have really great diversity down there. When we're looking at the microbiome, we do want to remember that the amount of microbial cells that we have relative to human cells is about 1-to-1. But then when we look at the genes outnumber our human genes at a ratio of greater than 100-to-1, meaning we are much, much, much more of the microbes than we are of the human. So I always say the takeaway is we have to be nice to our microbiome. First and foremost, we want to talk to it. We want to love it. And that's all your microbiomes, the microbiomes in your skin, in your eyes, in your ears, down your mouth, all the way through the intestinal tract. For women, in the vagina. Like, we want to really love up on all these microbiomes because they change drastically as she's moving through menopause, and she will report that to you. Or if you're listening to this and maybe you are a practitioner who is going through the menopausal transition, you may be nodding along going, yeah, that's exactly what's happening to me. All these are shifting. Now, we have key shifts in our microbiome in our life as humans. So we transition to solid food. That's a big shift. We go through puberty and adolescence. That's a big shift. And our diversity continues with age until about 40 years old. Now, for women, the new frontier is what's happening in menopause. So we have diversity hopefully going up and the development of our microbiome going up through the years. And then with the change of hormones, everything starts to go down unless you do something about it, unless you interfere for good ways. So estradiol and progesterone actually help maintain the gut barrier and protect it from gut injury, which says a lot for these hormones. Mainstream medicine, conventional medicine, talks about estradiol and progesterone really only in terms of the uterus with fertility. But we have to remember that we have receptors, male and female, all over the body for these two hormones. So it stands to reason that we would have a lot of receptors in the GI tract. And for women going through the transition, the loss of estradiol and progesterone is going to affect that. So I have a summary of just some of the keynotes that come up in the literature of how these hormones do affect the health down there. So for example, estradiol treatment, giving estradiol protects the mucus-producing intestinal epithelial cells against oxidative injury. So there are a lot of things that can protect those cells, but estradiol is one of them. It's a big one. And for a lot of women who are cycling, of course, they make a lot of estrogen. Depending if they're in the follicular or luteal phase, that can really support the GI tract. This is also why women who are cycling may notice more GI-related symptoms as they get close to their period in the PMS time because of the change, the big shifts in estradiol and progesterone at that time. Now, both estradiol and progesterone help maintain and improve the barrier function. So basically, they help upregulate those tight junction proteins. So they play a role. They don't play the only role, but they play a big role. So now let's imagine you have somebody who has leaky gut going into this transition, and then they lose their progesterone because that's the first to decline. They don't do anything about it. They don't know to seek treatment. And then they start to lose their estradiol. Their GI symptoms, their leaky gut is probably only going to get worse. So this is why we want to really start to focus almost when we work with our fertility clients and patients, we are doing pre-fertility work, hopefully, that ideally, if we have enough time. We want to do pre-fertility. So we want to kind of do perimenopausal work as well. We want that to be the new normal of like, hey, you're in your 30s. Let's start prepping. Let's start maintaining now, because the minute you start to have these hormones change, I don't want it to be too late or to feel like we're behind the eight ball. So in vivo studies, ovarectomy has been shown to increase intestinal permeability in mice. So we see it both in humans and we see it in mice. So this is how it's being studied right now. And I'm really excited to see a lot more human studies, given all the studies out there on the microbiome in general, but specific to women going through this whole transition. And going from a pre to a postmenopausal woman, according to the SWAN study, all sorts of inflammatory things unfortunately happen. So we have plasma intestinal fatty acid binding protein, lipopolysaccharide binding protein, that's LPS, binding protein, LPS being the very inflammatory release of gram-negative bacteria that, of course, can result in endotoxemia, and CD14, so one of the cytokines, all increase. So that's not good. That just puts her into an inflammatory state. And unfortunately, postmenopausal women have less short-chain fatty acid producers, such as Faecobacterium and Roseburia. So short-chain fatty acids, we are going to touch a lot about when we get to the treatment section, then when we get to the, like, what do you do section, because we know in functional medicine, integrative medicine, alternative medicine, we have a lot of ways to support tight junctions, how to reduce inflammation, support the microbiome, and get those short-chain fatty acids up. And lastly, as I said, because of that leaky gut, you get the increased microbial translocation, which basically means the gram-negative bacteria release LPS. Because of the leaky gut, LPS crosses into the bloodstream. The immune system gets mad, it reacts, and now we have an entire either high-grade or low-grade inflammatory state as she's making this transition. And it can all start in the gut. And she may not have a ton of gut symptoms, but she does have a lot of systemic inflammatory symptoms, or she just presents with a lot of inflammatory type symptoms that, again, maybe not heartburn, maybe not gas and bloating, constipation, diarrhea, maybe. But what's happening is these changes in the gut are causing the immune system to react there. And now we have an upregulated immune system, low grade or high grade all the time. So when we're looking at this and we're looking as she's making this transition, I'd be remiss if I didn't talk about the blood sugar insulin aspect, because the visceral adipose gain is common, even though we don't want it for her, as she makes this transition. So what they're saying is that with estrogen's depletion is associated with insulin resistance in the female body, which is pretty well known at this point. We know that our clients and patients, as they get older, their glucose, their triglycerides, their insulin, without changing anything, tends to go up because of the loss of estradiol. What this study is saying is through various metabolites, i.e., short chain fatty acids, secondary bile acids, serotonin, the gut microbiota plays a significant role in regulating glucose homeostasis, oxidative stress, type 2 diabetes associated pro-inflammatory cytokines. It's coming back to the gut in relation to estradiol. Now, unfortunately, I don't have the time today to get really into the secondary bile acid situation, but that is a huge player. Whether she has a gallbladder or not, supporting her bile with something like TUDCA or herbs that are bitters, things that are known to support bile, is only going to help as she makes this transition. I am largely just going to focus on the microbiome aspect of today. Now, this is a great slide as it relates to type 2 diabetes because, again, I have the smiley face on the left. I've added that on this research picture, and the frowny face on the right. So when we're smiling and happy and the gut microbiome is good, we have our Bacteroides, we have the Bifidobacterium, we have our Akkermansia. Akkermansia is what helps keep our mucin layer thick and healthy and strong and good. We have our butyrate producers. Those are our big short chain fatty acid producers that make butyrate for the large intestinal cells. We've got good estrogen metabolism. We have good energy expenditure. We have low BMI, or let's say they say low BMI. Let's say appropriate, normal, in range BMI. We have good glucose uptake by the muscles, so we don't really need as much insulin, but overall we have good insulin sensitivity. This is what's ideal. As she moves into completely the postmenopausal transition, now she starts to shift without doing anything on her own. She shifts more into firmicutes. All of a sudden, E. coli and pathobiotics are starting to show on stool testing that maybe you're doing. Now she has dyslipidemia. She didn't change anything yet. Everything's changing. All her lipid profile is starting to get worse. Triglycerides are going up. Apolipoprotein B is going up. We have more gluconeogenesis and adipogenesis. As she doesn't have that estradiol support and she doesn't have the GI effect on the glucose, then she's going to have issues with how she utilizes that glucose, and it often ends up being stored locally around the liver. So now we're prone to fatty liver and we're prone to more visceral fat gain. We're getting more low-grade inflammation. Now she's hedging into obesity and her blood glucose levels are going up. This, of course, is if she does nothing. And we see this all the time in our patients and clients. We can just go to the airport, go to a big box store and see this in the people walking around, that this is the trend that can happen even when they do nothing. They don't realize it. They're just getting older and they're like, I don't understand. I didn't change anything. I've gained all this weight. I don't understand. I didn't change anything. And now my blood sugar is pre-diabetic or diabetic. I don't understand. I didn't change anything. And now I'm on a statin. What's going on? Well, as this research is unraveling and we're coming back to the gut as a big part of it, we are now understanding what's happening. And as usual, as with everything in the entire, functional medicine ecosystem, we talk about the gut-brain axis. So anything that happens to the gut surely does not stay in the gut. It can go right up to the brain. And affect everything from the microglial cells to the immune system up there to the neurotransmitters up there, and then vice versa. If the brain's not happy, it comes right back down and affects the way that the gut does or doesn't work. And so this whole axis is so important, especially as she's going through menopause. Now, when it comes to symptoms, and we're talking about the brain, in 2023, Andrea Donsky and her team at Morphus did a whole survey. They interviewed over 3,000 perimenopausal and menopausal women, and they collated the answers to determine what were the top 10 symptoms women reported. And you can see all the symptoms here: fatigue, brain fog, sleep issues, memory loss, anxiety, joint pain, concentration, focus, hot flashes, libido. Now, honestly, some of these do overlap, but this is how these women report it. So they may not have understood lack of concentration, but they knew that they couldn't focus, as an example. So these were as reported by these women. What you will notice is 9 out of the 10 directly relate to the brain. They have brain issues. The only one not directly related to the brain is joint pain. Joint pain is a little bit different. Now, you could argue it's related to the brain, but really in relation to the other 9, brain fog, anxiety, memory loss, even hot flashes, right? For women, their thermoregulatory center is in the hypothalamus, in the brain. So it's very brain related. that a lot of women need brain help as much as they likely need gut help because of the gut-brain axis. So when we're looking at this, and this study specifically is on neurodegenerative disease, when we're looking at, and you can see at the very top, there's in purple, it says reproductive phase into the menopausal transition, which is what we've been talking about, into the postmenopausal. Well, as you're coming down through perimenopause, all of a sudden, we have this inflammasome, right? It's the inflammaging. So these pro-inflammatory everything are going up. They are crossing into the blood-brain barrier, so all these cytokines going up, and now we have activation of the pro-inflammatory factors. This leads to those 9 symptoms, along with other changes as she's going through perimenopause, such as the direct decline of progesterone and estradiol alone. And so I'm just helping you build the case of like, oh my goodness, we talk in circles around inflammation for everybody and chronic disease, but specifically for women going through this transition, we need to put inflammation in the GI tract, in the brain. And if this was a different webinar, we would talk about inflammation everywhere else, in the skin, in the joints, in the muscles, right? She's reporting these symptoms because of the shift in hormones and inflammation. So when we're looking at this, you can see microglia in neuroinflammation and neurodegeneration from understanding to therapy. This is 2021. So sustained or chronic activation of microglia, of course, up in our brain, can lead to irreversible central nervous system damage. Indeed, persistent inflammation, again, there's the word, in the brain affects neuronal plasticity, impairs memory, and is generally considered a typical driver of tissue damage in neurodegenerative disorders. When we are working with women going through this transition, we have the 4 horsemen, or the 4 horse women of the apocalypse, not the 4 horsemen. And they are things that we're trying to avoid. So we're trying to avoid cancer or minimize the risk. We are trying to avoid cardiometabolic disease. So the metabolic we've just touched on. We're trying to avoid or minimize the diseases of frailty, such as osteoporosis, fracture. And we are trying to minimize or avoid the neurodegenerative disease. So we already know the decline in estradiol and progesterone can play a role. That's still actively being researched by, some really amazing brain researchers, such as Dr. Lisa Mosconi. However, over and over and over, you're going to see neuroinflammation, inflammation, and just keep in mind the relation to that in the GI tract. This study from 2023, the study of women's health across the nation, so SWAN study, found that being perimenopausal confers a high risk for the reoccurrence of major depressive disorder. Major depressive disorder. So again, while we're talking inflammation, activation of microglial, worst case scenario is the neurodegeneration, the dementia, the Alzheimer's. But as we move down that scale, we have to remember things such as depression and anxiety and panic. And women going through this transition often report those symptoms, especially if they had it while premenopausal in their cycling years. So if they were prone to it, oftentimes I found my patients were like, man, I thought I had this under control and now it's back. My depression is really crazy and I wasn't expecting it. So you definitely want to keep that in mind, that the change in hormones and how it potentially could also be related to the gut goes with even mood for depression. With this, they have this great chart. So you can see major risk factors, minor risk factors, and this is for developing menopausal depression or anxiety, or protective factors. So major risk factors, vasomotor symptoms, which is a brain issue, and an estradiol issue. Vasomotor symptoms typically because if they have them frequently, if they're unrelenting, then plays a big role in the mood. If they already have a history of major depressive disorder, I would also argue if they just have a history, it doesn't have to be major depression, major depressive disorder, but if they've even had a history of depression in their life, or they maybe report to you that they have a history of like, well, I'm not the happiest, or I wouldn't say depression, but I kind of like skirt that edge. That when my patients would say that, I'm like, okay, maybe you haven't been clinically diagnosed, but that does mean I think it puts you at a higher risk. So then we have neuroticism, stressful life events, and low financial or educational status. Those are major risk factors. Minor risk factors, lack of social support, and this can be really hard because as women go through this transition, the change in hormones often makes them feel more isolated. They don't like how they feel. They don't like what's going on. And the change in the hormones estradiol plays a role in their oxytocin. And oxytocin is a bonding hormone. And so women will report to me, I don't feel like being social like I used to. I feel more introverted compared to before. I don't want to go out and hang out. I'm declining things. Now, of course, it's not everybody, but it is not uncommon, and that plays a role. So lack of social support may be because they truly have no support, and or it could be because they're not seeking it out. They don't want to anymore. They're not feeling that. So you're going to want to check in with them about that. If you have an intake form, don't forget to ask about social support, and are they seeking out social support? If they're single or divorced, and again, it's around social support, negative perception of aging or menopause, which is completely fair because of the education that we've had over the last couple decades, which is next to none. And so women were told to toughen up, like, well, that's a part of getting older. That's what happens. Good luck. And that tide is completely changing as it relates to education around menopause. And then history of premenstrual disorder, or PMDD. And then you can see, of course, all the protective factors are the things that we actively educate on all the time. Social support, hormone therapy, counseling, psychological therapy, even just them coming to talk to you about it. Healthy lifestyle, including exercise, meditation, mindfulness, again, stress-based practices or stress relief-based practices, the things that are the core foundation when you're working with a woman. This one talks about serotonin neurotransmission and the implication for female depression. Estradiol plays a major role in serotonin. When women have low levels of serotonin, then they can struggle to get from tryptophan to 5-HTP, which goes on to make serotonin. And so just the mere act of losing estradiol can increase her risk of not making enough serotonin, not getting from tryptophan to 5-HTP. And so by understanding this, the physiology behind it, it makes it easier when somebody comes in and goes, I'm feeling really low, or I'm feeling really depressed. And oh, by the way, I've been skipping periods. Or if you choose to test them, their estradiol is really low. Then you're like, oh, I can put this together. I know what's going on. Now, estradiol is not the only hormone that plays a role in all of the mood, right? We have the neurosteroid allopregnanolone. And allopregnanolone is a downstream metabolite of progesterone, which is one of the great reasons that we do the Dutch test, because we can see that alpha pregnanediol, which I'll show you in just a second. But when we have the allo up in the brain as a neurosteroid, then it's not only helpful for GABA, but it is helpful to block the pro-inflammatory neuroimmune signaling. So women often will go on, as an example, oral progesterone, and they will go, oh, I feel so much better. I feel calmer. I feel nicer. I feel less irritated, and I can sleep. Now, I realize it's not everybody who has that response, but it's significant. It's usually a lot. And this is one of the reasons for that. So it's not just estradiol, but it is that alpha side of the progesterone family. As you can see, when you're looking at a Dutch test, you're looking on page 3 in particular in the upper right-hand corner, and you will see that alpha pregnanediol, that goes on to break down into allo. And so when it's really low like this, and they're saying, I don't feel calm, I feel really irritated, I can't sleep, this is where that doing oral progesterone, or even pregnenolone, oral pregnenolone in some cases, can be really helpful for the brain aspect, for the mood aspect. Now, what about other hormones? What about testosterone? Well, rising levels of testosterone, and more specifically, the ratio between testosterone and estradiol during perimenopause, has been linked to increased depressive symptoms as well. Now, we often think about testosterone in relation to maybe anger and irritation, but again, it's a ratio between the two of them. So if we're looking on page 3 of the Dutch test, I will eyeball testosterone there at 12.7. And in this case, this is a 49-year-old perimenopausal woman with regular cycles. So she's still making estrogen. However, the estradiol is low and the testosterone diol is at the high end, or I should say the estradiol is lower and the testosterone is higher. So when I see this, I definitely am like, let's talk about your mood. What's going on with your mood? How are you feeling? Now, the other thing I will talk about in this is weight gain. Research is showing that the testosterone estradiol ratio is a contributing factor to that visceral adipose weight gain, the android body shape that a lot of women develop as they move through into, late perimenopause into postmenopause. So just by looking at these dials, are they facing the same direction? Or is the testosterone dial, like if you were to think of this as a clock, is the testosterone clock higher compared to the estradiol? Like this exact example, I would say, let's talk about inflammation. Let's talk about metabolic health. Let's talk about, is weight gain an issue for you? And often on the intake form, they'll let you know. They will let you know if they have gained weight and they've been trying to lose weight. So not only think about mood when you see this on the Dutch test, but think about the metabolic health aspect of it as well. Now, that ratio, the testosterone to estradiol ratio, is not set in stone, as in, like, I don't know what the ratio is. They just know in the literature if testosterone, there are healthy levels of testosterone, but lower levels of estradiol. That's what they mean by an unhealthy ratio. So it's easy to eyeball because it's easy, even in blood work, you could look at blood work and go, well, their testosterone's good, but their estrogen's low, completely out of whack, right? They're testosterone dominant, and that's what's going to contribute to these symptoms. So in this case, I would argue, because you may ask, should they go on, which hormone do I put them on first? Well, this is why I like to do some testing, at least of even the androgens, because this person I would not put on testosterone. If this person is going to go on hormones besides progesterone, which they're already on, then I would add an estradiol next if they're a candidate, because I wouldn't want to push the testosterone further and drive up this ratio, so worsen the depressive moods and worsen their metabolic health. Now, this is a 66-year-old woman not on any HRT, and you can even see her testosterone is not fallen below the star. She's at 5.86. So to have that testosterone, really pretty decent for a 66-year-old, but look at her estradiol, 0.42. So she's down in the postmenopausal range, but relative to testosterone. Again, I'm checking in with her about her mood and depression, and I'm checking with her about the visceral adiposity, gaining weight, especially in the Android or Apple shape, like what's going on, as this ratio can be a contributing factor. Now, what's really interesting and irritates the heck out of me, and I have to put it in here, is that despite all of this we know, despite all the clinical and the research and the anecdotal evidence, the Harvard Gazette came out in September 2024 and said menopause depression risk has been exaggerated. And I was really irritated. So much so, I had to put it in this webinar so that we could collectively roll our eyes, because I think this does a lot more harm than good. And for women who do have depression, and maybe it's not clinically diagnosed major depression disorder, but let's say somebody is just feeling blue. They're just not feeling themselves lately. They're just feeling more down and out. They're being more introverted. They're not going out with their friends and their family, and you start asking them about it, and they read this article and they're like, well, it's been exaggerated. It's probably just me. It's probably no big deal. It's probably just this time of my life. And so I think it can do more harm than good than women who are going, I wonder what's wrong with me right now. And then they read this and they're like, well, I guess it's not depression, and they don't seek the help that they need. So I wanted to include this because ACOG, the American College of Obstetricians and Gynecologists, literally has an article that says mood changes during perimenopause are real. Here's what to know. So please, as part of your education, whether it's through your website, your talking, your social media, direct to your patients and clients, let them know the mood changes are real, and there are a lot of things that you can do around it. And if ACOG says the mood changes are real, the changes are real. Don't listen to the Harvard Gazette. That's just irritating. But I had to put that out there because there are still groups that downplay perimenopause and menopause, and I don't think that's fair. Okay, so we set the scene. Where do you start? So first and foremost, you have to be nice to your whole microbiome, from the mouth all the way down. Second of all, we have to get into addressing gut dysbiosis and lack of diversity. Then we have to support the low short-chain fatty acid and deal with inflammation. I mentioned earlier, just because we don't have time in this particular webinar, but you don't want to forget about bile and gallbladder if they have one. So definitely make sure you're including bile acids or assessing that is part of the overall plan. So as I said, we start in the mouth, always. The mouth is the top of the GI tract. So even if other symptoms are lower GI tract, we always start at the top. So anything around the oral cavity, some supportive ideas, make sure they're brushing their teeth. And you have to ask them, are you brushing your teeth every day? How often do you brush your teeth? Flossing, do you floss every day? How often are you flossing? Considering tongue scraping, which I know is not mainstream, but it's something to talk to them about. Regular dental visits, especially as they're going through this transition. Addressing any inflamed gums and tooth infections. If they have mouth microbiome issues, they're just swallowing that down right into the stomach, right into the intestines. So if we can address the mouth, then the downstream effect is only going to be very, very positive. You want to be very mindful of mouthwash. Are they using mouthwash with full of fluoride? Are they using it with full of like purple or green or blue colors? You want to be mindful of mouth breathing. Do they know if they mouth breathe? Has somebody told them they mouth breathe? Do they snore? Do they have sleep apnea? All of that is going to impact the oral microbiome. And then lastly, being mindful of all things fluoride. So in their toothpaste, in their water, in their mouthwash, that could be a real issue. And a lot of really interesting legislation is coming out around fluoride for the United States. So that's something to keep an eye on as well. Then we get into, we're still in the mouth, chew your food. You are not a snake. I use this slide all the time in a lot of lectures because one, it makes people laugh. And two, they're like, I know, I need to chew my food. And especially for practitioners who are super busy and they don't have time and they're on the go and they're trying to eat and respond to texts and email and finish chart notes at the same time. And they're not realizing they're not chewing their food into teeny tiny itty bitty little particles, which is only going to help digestion better. Remember, if you're not chewing your food and you're chewing food into really big whole pieces, and then it gets down into your intestines, which has leaky gut, your risk for that translocation goes up if the bacteria, if the acid in the stomach and the bacteria in the intestines aren't that great, then now you're going to have food issues. So we have to be careful of that. We want to make sure you're chewing your food. Don't just unhinge your jaw and shovel it in. And tell your patients and clients too, make sure they're chewing their food. Then we get into stool testing. Now, I am not going to spend hardly any time on stool testing because this is not a stool testing webinar. However, if it fits the case, then definitely consider stool testing. See what's going on. See what their inflammatory markers are. See what their good bacteria, their bad bacteria. See what their bile information, their short chain fatty acids, their beta glucuronidase, their secretory IgA. Like really get a picture of what's going on. And even better, again, is part of that whole. Remember when I mentioned pre-fertility, right? This is like your pre-perimenopause. If you've got a stool test early on with them, if somebody's been seeing you a while and now you can do it again as they're making this transition and compare, like what's going on with your stool and how can we best support this? So speaking of supporting, eating for diversity. What happens is adults get stuck in a rut. I guarantee you, when you go out to dinner at your favorite restaurants, you order the same thing every time. You order the same thing at Mexican, you order the same thing at Thai food, you order the same thing at your local restaurant up the street, you get the same thing when you get, Uber Eats delivered. You eat the same things, through the week. So we want to increase diversity. Start adding in either seasonal fare that you don't normally eat, or even, if you're a meat eater, start switching out meats. If you only eat chicken, maybe switch to turkey. Like if you only eat beef, let's try bison, right? Let's start to rotate around some things and get new exposures down there to the gut microbiome because we know the shift in a microbiome can happen with foods pretty quickly. Now, it may not necessarily stay, but we're just trying to give it something new and fun to do with. So if you don't, like on this picture I love, like if you don't ever eat artichoke, try artichoke. Have an artichoke, right? If you don't normally eat broccoli, try broccoli. If you normally always eat broccoli, try cauliflower. Right? Just switching up here and there, give some diversity into the way. If you normally eat a certain way, you eat the same, carb, fat, protein every single day, maybe throw in some variation. Like 1 day or 2 days do keto, and then 2 days do high carb, and then go back to your regular way of eating. Just giving your GI tract some diversity at this time, actually for men and women, but since the focus is on women, can be so helpful. Now, unfortunately, with diversity, consider leaving alcohol out of that diversity. And that includes vodka soda, because everyone's like, well, Carrie, I can do vodka soda because that doesn't affect my blood sugar, which you mentioned earlier. Still alcohol, you still have to process it. It still can affect your gut microbiome. Or the organic, low sugar, biodynamic wine. I know, I understand the premise behind it. But if you're having a lot of inflammation and microbiome issues, then you're going to want to leave that out of the diversity equation. And specifically for women. Now, when I say you should consider leaving it out, I mean everybody who's having those symptoms. But specifically for women, their liver enzymes are changing as they're making this transition, and they often really struggle to break down alcohol relative to their younger years. So having that talk with your client or patient around alcohol intake, if that's an issue, even if it's a small issue, even if they're like, oh, I only have 2 to 4 on a weekend. I don't have it every day. But they notice those couple of days, they don't sleep, they don't feel as well, they feel more bloated, they feel more puffy. Let's try cutting it out for a while and see what happens. Now, common food preservatives. So be mindful of all the common antimicrobials that are out there. So in this February 2024 analysis of a common preservative used to kill pathogens in food shows that it affects beneficial bacteria as well, threatening the healthy balance of the gut microbiome. Remember, in anything that gets passed through the FDA, will it kill the person, right? They're like evaluating, will this thing kill a person? But what they're not evaluating, and they never will, probably in our lifetime, is it killing the microbiome? So these common food preservatives are not killing us as a person per se. Like we're not going to, overdose on a paraben in a food or a lipstick or something like that at that level. However, what it could affect negatively big time is the microbiome. And that's what people are starting to argue of like, hey, let's just be a little more conscious because a food preservative kills bacteria. And that's what we're made up of as humans. And sure, extrapolate, but at the same time, they're starting to look at it. So something to think about with your patients and clients. Now, when it comes to food, prebiotics and prebiotic examples are so helpful. So a prebiotic is a substrate that is selectively used by host microorganisms, conferring a health benefit. And we've got garlic, Jerusalem artichokes, jicama. Jicama is my absolute favorite. I have a slide on it in a second. But it always trips people up in the grocery store because I will buy jicama, a full round jicama, and they'll look at it for a second. And the OGs in my grocery store, they're like, "Is this jicama?" But the newbies are always like, "I don't have any idea what this is." I'm like, "Oh, it's jicama with a J." So that one you may have to explain to the people at your grocery store. But adding in dandelion greens, adding in more onions, pectin, inulin, and these are just some examples. There's a whole big list, of course. But if you're looking at this list and thinking, "Man, I don't really ever eat those things, or I eat them pretty rarely," then including them as part of your diversity will help, and same for your patients and clients going through this transition. So what is jicama? That's what jicama looks like. It's an edible tuber, oddly enough, in the pea family. It is slightly sweet and starchy and crunchy. So I do just what they do. I peel it. I cut off all the brown part and then cut it up into sticks, essentially. And I'll add olive oil, or I'll add sea salt. I'll add in, cayenne. Like I'll add, depending what I'm feeling, I'll add in. And then it's a half a cup, has 40 calories and 5 grams of fiber. So it's a great filler and great for diversity, especially because if you've never had jicama or don't have it ever, hardly ever, it's a good one to throw in there for the gut microbiome. Well, that leads me, of course, to resistant starches. And resistant starches are kind of all over. They've made all over social media, that's for sure, with good reason. So resistant starch is the portion of the starch that can resist digestion by human pancreatic amylase in the small intestine and thus reach the colon to be fermented, thus modulating the microbiome. So you've probably seen big lists: beans, lentils, boiled then cooled rice, boiled then cooled potatoes, greener bananas as opposed to yellow bananas, guar gum is an example. All these resistant starches is they're trying to help the large intestines. We're trying to support and love on the large intestines. And again, you can create meal plans for people, or have AI create meal plans for people, increasing diversity, increasing their prebiotic foods, and increasing resistant starch foods. Now, we've got pre, pro, and then we have postbiotics. Postbiotics are a preparation of an inanimate microorganisms and or their components that again confers a health benefit on the host. So a postbiotic are things such as dead Akkermansia. So dead Akkermansia, dead meaning like the supplement, dead Akkermansia. You have Akkermansia as a human in your GI tract. And so, but by using as a supplement the dead Akkermansia as an example, it supports the mucin layer. And they know that Akkermansia plays a role in blood pressure, inflammation, it lowers LPS, and metabolic syndrome. I will be really curious on the researchers. For example, the big researchers at it, there's some big researchers out of Italy that are looking to see if I had them. I don't think I have them at the bottom on if I've quoted their articles, but I have heard them talk at conferences before on the role studying Akkermansia, especially studying Akkermansia in perimenopausal and then postmenopausal women. So what they've found is that the low levels of Akkermansia alive in the GI tract can be healthy in a premenopausal woman. So those of you who've done a stool test on a woman who's cycling and noticed her Akkermansia is just fine, great. However, what they think is as estradiol goes down, that Akkermansia level is going to go down. So you may notice in a patient or client you've been seeing for a long time that you did a GI tract test on her in her 30s, and now you do it in her late 40s, and you're like, oh my gosh, your akkermansia is completely changed. So giving what's called pasteurized or dead akkermansia is considered a postbiotic. You can also include this with foods. You can have them do pomegranate, either juice or seeds, and grape seed. Not grapefruit seed, but grape seed. So make sure you don't confuse those two. Not grapefruit seed, grape seed support akkermansia and the production of akkermansia. And again, that mucin layer is the mucus layer essentially, right? It's like the snotty layer in the large intestines that traps the bad stuff so that the immune system, you can either flush it out, or the immune system can take care of it. And we don't want that snotty layer to get thin, and we don't want it to get holy. So we want akkermansia to be able to do its job to eat up bad mucin that's like thin or not doing well, and then have more of the mucus layer laid down. Short chain fatty acids are also considered a postbiotic, and these are probably the most famous by all. So short chain fatty acids, gut microbiota produce fermentation products of dietary fibers. Basically, as it was explained to me, it's what the microbiome poop out. Don't you love that? We're talking about the GI tract, and that's a postbiotic. So we have some big ones. You're probably the most familiar with butyrate, maybe propionate, but we have several as humans. We have several short chain fatty acids. So butyrate being the big one, it's the energy source for the cells of the colon, so the colonocytes. And that's really important, especially given all the news, I think, around the increase in inflammatory bowel disease and colon cancer. So we want those colonocytes to be as healthy as possible. So you can see that there are some main butyrate producers there. And then we have Ruminococcus significantly contributes to producing butyrate through fermenting resistant starch. This is why you are starting to see the idea of resistant starch as a food and as a product all over, because we're trying to improve short chain fatty acids. Now, akkermansia is also helpful for propionate. Whereas we've got the ones up above for butyrate, akkermansia not only supports the mucin layer, but the propionate, so we can help that mucin layer directly. So you can see by using prebiotics, probiotics, resistant starches, and postbiotics, we can hit multiple areas to support the GI tract. Now, I like this graphic because it shows in the yellow the functions of a short chain fatty acid. And so when they give on the right-hand side where it says overall function in yellow, food digestion, drug metabolism, eliminates toxins, trains immunity, we want that, regulates neurological functions, and regulates endocrinological functions. That's us. That's this webinar. We have the gut-brain axis that we're talking about as a woman is making this transition. So even just including more of these foods in for her, creating dietary plans for her that include this, or if you're going to add in supplements for her around prebiotics, postbiotics, resistant starches, etc., for short chain fatty acids, you're only going to help her. We're going to protect that gut from inflammation, maintain the integrity of the gut barrier as best as we can. And this is assuming she's not on estrogen. You've not put her on any hormone therapy. This is independent of the hormone therapy, which we will get to that. You're going to help her nutrient absorb. You're going to help reduce the risk of infection and translocation. So supporting the gut as she makes this whole transition through peri and postmenopause, huge. You have to do it. Now, of course, that leads me to lastly, what about HRT? That's the big question. This research is really just starting. There's another study that I was going to put in here, and they talk about how we think HRT, specifically estradiol, is what they're looking at. We think HRT can play a very big positive role in the health of the GI tract as she makes this transition, but there's not a lot of research. And in fact, I forget the word they use, but they use this word that's like this whole area of menopause and the microbiome needs help. Like we need to go in that direction. But then this study was actually sent to me, and it says, in this study, we demonstrate that the core duodenal microbiome at phylum level is significantly different in postmenopausal women, which we've been talking about, when compared with women of reproductive age. And then that these differences are lessened in postmenopausal women taking hormone therapy. So giving women estradiol specifically has been shown to, on its own, support all the GI changes, the microbiome changes. And we know, as I mentioned earlier, estradiol plays a role in the metabolic part, so insulin, lipids, glucose, and we know estradiol plays a role not only in serotonin. I showed studies on serotonin, but I didn't show studies on dopamine, but estradiol absolutely plays a role on dopamine as well. However, if we can go right for the gut right away, if you can start getting her in her 30s, early 40s of like, we need you to start diversifying your diet. We need you to start adding in these foods. We need you to consider these supplements if things are bad, or maybe you've gotten to her, later. And if she's a candidate for HRT and that's the direction you want her to go and she wants to go, that's like the icing on the cake. That's even better on top. But what I love about talking about all this as it relates to women making this transition in the GI tract is that we have so much at our fingertips. We have so much at our fingertips between, again, the food and the supplemental aspect to support women from a GI aspect, that it's only going to improve the cardiometabolic and, of course, the neural aspect as well. Now, is it going to be the absolute only thing in your tool bag? Of course not. But it is going to be a big one, and it is not talked about nearly enough, although I am seeing it more and more. So to be in on this webinar at this time that it's that we're doing it is honestly leading edge. It's honestly pretty cutting edge because everyone's so focused on HRT alone, or they're focused on if you're not going to do HRT, then like, let's focus on other foundations. Let's focus on sleep and stress, which are very important. But I'm like, well, what about the inflammation? What about the fact that we know her transitioning through this menopausal area of her life is a pro-inflammatory state? And a lot of it starts because of the translocation that's occurring through the leaky gut in the GI tract. And we are absolutely the experts of all things happening in the GI tract and how to support it from a holistic functional point of view. So in summary, the perimenopausal transition is linked with increased leaky gut, less microbial diversity, increased systemic inflammation, increased depression, and increased brain changes. So using everything you've just learned today, you're going to mad stack that in your toolbox as a first line basis as part of your foundations. Even if your patient or client's like, I'm not doing any more supplements, like from a dietary point of view, there is so much we can do. Even from like, hey, I know you said that you go out to eat, Monday, Wednesday, Friday, or Friday, Saturday, Sunday. Like, I need you to start ordering different things. I need you to start rotating in jicama here and there. I need you to start, adding in foods you don't normally eat here and there. Try different berries, try different fruits, try different veggies. Switch up your meat a little bit. If you always eat chicken, eat turkey. If you always eat beef, try bison. Like, these types of changes are a great start for somebody who's never changed, but yet everything is changing. If they're more advanced, now you have more advanced. Now we have the supplements to add in. If they're open to HRT, we can add in the HRT. We know how to address the GI tract and the microbiome. So by understanding this, you're going to reduce inflammation and improve diversity by therefore reducing, again, those 4 horsewomen of the apocalypse of aging. You're going to reduce a lot of their symptoms and risks, and they're going to feel so much better. And as I said, as of right now, not a lot of people are talking about it. So let's talk about the gut in this transition. Let's advocate for more research for menopausal women, see where they're at. And with that, I thank you.
Thank you so much, Dr. Carrie Jones, for that wonderful, fabulous webinar. We always learn so much from you. We appreciate you being with us today. And thank you to our listeners. We hope you learned something helpful. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research. And make sure to visit the Become a Provider tab at dutchtest.com to register for an account so you can gain access to even more hormone education and research. Be sure to follow at Dutch Test and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.